Yes, the last presentation in this session by Professor Paul Whelton. Professor Paul Whelton is a personal friend of mine. I knew him now for more than 30 years, and since he was at the Johns Hopkins University, now he is chairman of department at Tulane University, and he's a very active and amiable person. Unfortunately, he will not be able to communicate with us directly. Just we will going to listen to his video presentation.
Hello, this is Dr. Paul Whelton. It's always a pleasure to be back with my friends in Egypt. And today I'm going to talk about blood pressure lowering for stroke prevention. I'm speaking to you as the Whelton professor from Tulane University in New Orleans, and in my role as president of the World Hypertension League, and I have no conflicts of interest. So obviously stroke is common. It has enormous disability. Deaths as well, but especially disability. And in terms of disability, stroke contributes almost as much disability as ischemic heart disease. So it's clearly a very important outcome. And there are lots of nutritional factors and physical activity and alcohol related to stroke. They're all related. But the one that is most dramatically related is potassium. And potassium, no matter how you measure it, it is very closely related with stroke, as is consumption of fruits and vegetables, probably due to the potassium. So the higher the potassium intake, the lower, in observational studies, stroke risk, and the lower the potassium intake, the higher the stroke risk. There's also a strong association with salt, and we had a relatively recent trial, a large cluster design trial from rural China that showed dramatic effects of salt substitution, 25% substitution of potassium for sodium in salt. That resulted in significant reduction in stroke, non-fatal acute coronary syndrome, and all-cause mortality in stroke survivors and those who are at high risk for a stroke. And that's not the only trial. There have been others. And long-term follow-up of TOPE and TONE, when we've done randomized comparisons, those randomized to the lower sodium had much lower cardiovascular event rates. So we know that these non-pharmacological interventions are helpful, not only for reducing blood pressure in the context of trying to avoid stroke, but also they've been proven to reduce stroke risk and cardiovascular risk and all-cause mortality risk. We have a bigger volume of evidence for drug therapy. And we have evidence related to drug versus placebo, drug versus drug, number of drugs, intensity, and I'll cover some of that. So going back to the early studies, active treatment versus placebo. This is chlorthalidone primarily versus placebo in the SHEP trial. Stroke was the primary outcome, and as you can see, there was a dramatic benefit for stroke prevention and those treated with the active agent. Predominantly chlorthalidone, a little bit of atenolol. Going forward to a more recent group meta-analysis, is a large one, 123 randomized controlled trials pooled. Now we're treating people with lesser risk, so the relative reduction in risk is slightly lower, but still very dramatic, almost 30% reduction in risk for stroke and a very tight confidence interval. So obviously blood pressure lowering is very effective for prevention of stroke. And it works well in these trials in people who've had or have not had a cardiovascular event, although they're all at high risk. And it's worked well for those with a baseline blood pressure, systolic blood pressure of 130 and above. And that's in many of these meta-analyses. What about the choice of antihypertensive medication? Well, we know from meta-analysis that one class of agents, that's the beta blockers, are not particularly good for prevention of stroke. They stand out compared to all the other agents. ACE inhibitors, to a lesser extent, are not so good. They stand out to an extent, but not as much as beta blockers. So we don't recommend beta blockers for prevention of stroke. And in fact, in almost all guidelines, including the US guidelines, we don't recommend beta blockers as first step therapy for any hypertensive drug treatment unless there's a compelling indication. The best trial and most carefully designed trial to compare first step agents and really was very carefully designed with the same second, third, fourth level treatment, and the only differences were the randomization to a long-acting diuretic, chlorthalidone, or a calcium channel blocker, amlodipine, or an ACE inhibitor. At that time, lisinopril was the most common, lisinopril. The primary outcome was coronary heart disease. And when we look at the forest plot here, there's absolutely no evidence that these newer agents are any better than chlorthalidone for the primary outcome or for all-cause mortality. When we look at stroke, there are some slight differences for, again, for ACE inhibitor, not quite as good as chlorthalidone for prevention of stroke. The big difference, of course, is heart failure, where diuretic is way better than CCB for prevention and somewhat better than an ACE inhibitor. Well, when we do the meta-analysis again, just looking here visually, I think it's a nice one. Green is better, red is worse, yellow is the same. You see the drugs across the top here, beta blockers, calcium channel blockers, etc., and the outcomes down the side. And here are the comparator drugs, diuretics, beta blockers, etc. Well, you see straight away beta blockers not so good, again, for stroke, so we can strike those out. Calcium channel blockers not good for prevention of heart failure when you're treating older people particularly, and you're worried about heart failure, dementia, those sorts of outcomes. Calcium channel blockers not so great. ACE inhibitors, a little bit of red. Actually, the one where you see no red, it's all yellow or green, is diuretic. So for many years, the US guidelines recommended diuretics as first step. We've kind of simplified that now, said most of the benefit is blood pressure reduction. So either diuretic, calcium channel blocker, ACE inhibitor, or ARB are perfectly acceptable. And we know that most people are going to require more than one drug anyway. In ALLHAT, which was a 140/90 target, about half required two drugs. Now that's typical for the 140/90 trials. Obviously, they're spread around that average. For the one less than 120 trials, typically the mean has been about 3 meds with spread, and logical combinations of diuretic or CCB with a ACE or an ARB, and if 3 drugs are needed, diuretic, calcium channel blocker, ACE and ARB, and then we're getting into rare territory where you need 4 drugs. You're now into resistant hypertension. How about the intensity of treatment? How low should we go? There's been a lot of drugs or trials that have looked at this in various types of trials. So trials and meta-analysis have looked at differences in blood pressure for drug versus placebo, more versus less intensive. And probably the gold standard comparison would be looking at groups that have been randomized to different blood pressure targets. Meta-analysis have been group comparisons, individual participant data meta-analysis, and network meta-analysis. They've all shown lower is better. And this is the most powerful statistically. It's a network meta-analysis that my colleague Josh Bundy and a number of us published. And it basically shows the inverse of what we see observationally, that is in trials. The lower the blood pressure achieved, the better the outcome. And obviously, the higher the starting level, the bigger the statistical effect. Well, this is in pooling all those different types of trials. If you go to the gold standard trials, those who are randomized to different targets for blood pressure, there are 7 trials that have looked at the systolic less than 130, and I'm showing you here the trial, the study design, the intervention, the cardiovascular outcome, and the stroke outcome. And for stroke, you'll see there are 3 of them were statistically significant. Most of them were not powered to recognize a difference in stroke, but they all show the pattern of lower risk for stroke. So they're pretty compelling, really. And if you did a meta-analysis, this would be quite statistically significant. If you go one step further and look at the existing trials for less than 120 versus higher, the pattern is the same. It's not quite as convincing overall, and there are 3 trials yet to come in, the 2 optimal trials in Brazil and the BP Road trial in China. So we'll get more information here. So I would say pretty convincing evidence for less than 130 as a goal. Doesn't preclude going lower, and there's suggestive evidence certainly for less than 120. What about other outcomes? Well, one thing we looked at very carefully in SPRINT was brain function, not strokes so much, but cognitive impairment, dementia, and the composite outcome of both of those two. And within 6 months, for the more intensively treated group, that is the group randomized to less than 120 versus less than 140, we saw a statistically significant improvement or difference in cognitive impairment, less of it in the intensively treated group, and it was there throughout the trial and after the trial. We didn't have that many dementia events, but there was certainly a strong trend. And the composite with long-term follow-up of cognitive impairment and dementia was nominally significant. And in MRI imaging studies, where we were looking at dense white matter lesion that is usually an indicator of advancing dementia, there was less of that accumulating in the more intensively treated group. So strong evidence to suggest benefit. And now as we go forward, I didn't put it in here, but the community health-based led trial in rural China has shown a 15% highly significant reduction in dementia for the more intensively treated group. There, the target was less than 130. So I believe there's increasingly strong evidence that more intensive treatment to less than 130 and perhaps lower is beneficial for helping people with their cognitive function and preventing progression to dementia, in addition to the cardiovascular events and stroke. So with that as a little summary, I say shukran. I encourage you to come and join us for the World Hypertension League 6th World Hypertension Congress. We'll be holding this in India for the first time in Chennai from February 21st to 23rd. It'll be a who's who of all the major leaders in high blood pressure. There'll be abstracts, and there'll be workshops, and there'll be lots of other things going on. So I hope you can come. We in the World Hypertension League are very proud to have the Egyptian Hypertension Society as a very important member of our family. And I thank you very much for the invitation to join you today. Thank you. Bye-bye.
معلش في announcement. احنا السيشن اللي جايه باذن الله اخر سيشن، بعدها فيه جمعيه عموميه، وانا اتفقت مع اداره الفندق ان هي تبوستبون الغداء لمده نص ساعه يعني ولا حاجه. نعم. لا موجوده. نعم.
عايزين نتكلم مع الراجل بتاع اليو اس ده.
لا ده هو للاسف ريكوردد، بس للاسف ريكوردد للاسف.
طب نسالكم برضه يعني
انا عايز اسال سؤال دكتور سليمان، يعني بعد الساس ترايل في ناس دلوقتي قالت ان العمليه مش صوديوم الون ولكن بيرسنت صوديوم تو بوتاسيوم، وبقوا ريلاكتنت ان انت لو زودت الصوديوم وزودت البوتاسيوم معاه this may mitigate the effect of sodium. What's your thought about that?
عليكش خطأ بخطأ. يعني انت لو زودت الصوديوم، هو المشكله
لا،
في
هزود الصوديوم والبوتاسيوم.
هو انت ليه هتزود اتنين struggling with each other في البادي؟ انت لما تقلل الصوديوم تزود البوتاسيوم بتجين مور بنفيت. احنا هنكرم بس هنكرم دكتوره وفاء، تعالي بس دقيقه واحده لو سمحت، تعالي معانا. طيب تعالي، لا تعالي. طب نكرم هنكرم ده، هنديله الدرع بتاعه اللي هو
دكتور سليمان، دكتور سؤال تاني والنبي. هو دلوقتي اللي اقل من ال 120 الستروكس قلت، اللي اقل من ال 140 ماشي. طيب دلوقتي دوت ان جنرال ولا اكوردنج تو ذا ايج؟ انا واحد عنده 80 سنه او 85 سنه، مش ممكن اقعد عشان اوصل له 120.
لهم كاتيجوري معينه، لان الميتابوليزم بتاعه بيختلف والبادي ماس اندكس بتاعته بيختلف، لكن اعتقد ده هو في الميدل ايج جروب.
هو بعد اذنك يا دكتور اخلاص، كانت في الاستادي ده سبرنت ستادي دي، الحقيقه دي اتعملت من فتره طويله قوي، وبعد كده اتعمل ليها موديفيكيشن يمكن لغايه 2020. الاستادي دي غريبه جدا، كانت كلها على الناس الاولد ايج من فوق ال60، وكان في استادي تانية معموله اظن في الصين كانت عن حاجه اسمها الستيب استادي كانت فوق ال80. كلها قالت ان الانتنسيف ريدكشن اوف بلاد بريشر يجيت بنفيت عن النورمال او الستاندرد بلاد بريشر، ومقصود بالانتنسيف او المور يعني اللي هو تحت ال 120 80 بيجيت بنفيت في بيقلل الانسيدنس اوف ستروك وبيمنتين الكدني فانكشن ويل. بس طبعا الكلام ده الحقيقه، ويمكن الكلام ده ترتب عليه الجايد لاين بتاعت الهايبر تنشن الامريكان اللي هي خلت البلاد بريشر يسقط قوي او يبقى تحت قوي. انما دلوقتي الكلام اللوجيك والمنطق ان احنا ما بنحاولش نقلل البلاد بريشر على 130 80، لان لقوا ان الكلام ده ساعات بيعمل ديستربنس في السيريبرال سيركيوليشن.
يعني لينا الشرف ان احنا هنكرم الاساتذه الاجانب، مش الاجانب يعني اللي هم مش مصريين. فانا بقول الدكتور فارس، دكتور فارس عبد الكريم من العراق.
شكرا جزيلا.
We have to close this session and we'll ask the chairperson in the next session to come. Chairperson.